Hi, everybody. Welcome to our wellness group and seminar. Today, we have an amazing speaker, Dr. Marina Basina. She is one of our clinical professors at Stanford University Medical Center, Division of Endocrinology, Gerontology, and Metabolism. And she has really just such a wonderful speaker and actually has received awards such as a Master Teaching Award from Stanford because she's such a great teacher and gives so much of her time and her energy and knowledge to students and other physicians. She is also our chief for the inpatient and on many multiple boards to help support different missions around technology and diabetes. So without further ado, today we're going to, Dr. Basina is going to talk about pre-diabetes from an endocrinologist perspective. And so I will highlight you and then you can take it away. Thank you, Dr. Basina.
Thank you so much for a great introduction and welcome everyone to today's seminar. I'll try to make it kind of shorter version and then leaving time for questions. So feel free to leave question to the end. I don't think I will be able to see the chat if I'm on presenter view. So
I can help you with chat.
You can help. Okay, great. So I'm going to share my slides. Okay. So the talk was kind of initially planned and designed to discuss from pre-diabetes, diabetes prevention standpoint to what your doctor, what your endocrinologist would like you to know. So that was the sort of the main goal of the talk. So just wanted to give a little bit of the statistics on prediabetes. So what is prediabetes? It's sort of an intermediate state of glucose dysregulation. It's between normal and diabetes. It precedes type 2 diabetes. By statistics from 2021, it affected 720 million individuals worldwide. And by 2045, it's estimated to be affecting 1 billion people. In the United States, it's affecting approximately 10% of people. In the United States, for our statistics, approximately 10% of individuals with prediabetes will annually progress to overt diabetes. So the definition criteria, or for the blood glucose diagnostic criteria, somewhat differ between the different organizations. And I'm listed the dates and when the organization came up with the guidelines and what the numbers that were used for the diagnosis. So the most current one is 2023 American Diabetes Association guidelines, and now 2024 data came out. So those numbers have not changed, but the guidelines, just the updated guidelines just came out in January of 2024. So by those guidelines, fasting glucose between 100 and 125 to our post-meal glucose level, and that's usually from the first bite of the meal, not from the end of the meal, is between 140 and 199, and hemoglobin A1C between 5.7 and 6.4. So all those criteria will qualify for the diagnosis of prediabetes. And as you can see that the numbers are getting stricter. So before, with a World Health Organization in 2006, fasting glucose was defined as abnormal over 110. So we're actually getting to the tighter criteria for the diagnosis for having sort of alertness of the diabetes and diabetes prevention. As for hemoglobin A1C, until 2010, I believe, the assays, the laboratory, the way the laboratory measured hemoglobin A1C was not standardized. So in 2010, the American Diabetes Association recommended including hemoglobin A1C because assays were standardized across the laboratories to be used as a screening test as well. For how frequently do we screen or recommend screening? So American Diabetes Association recommends universal screening every 3 years for all adults 35 years or older, regardless of the risk factors. For screening tests, the tests that we use, fasting plasma glucose, hemoglobin A1C, or 2-hour post-glucose challenge. And that, again, usually includes a 75 gram of glucose that is given, the glucose drink that is given at the laboratory, and then blood glucose getting checked. 2 abnormal screening tests results, either from the same sample or 2 separate results, 2 separate test results needed to make a diagnosis. If prediabetes is diagnosed, then the recommendations are to go with annual monitoring in order to monitor for progression to the overt diabetes. So what is the pathophysiology of prediabetes? It includes several different organs and several different sort of factors. One is the development, and one of the most important one is the development of liver insulin resistance. So when liver does not no longer listen to the normal amount of insulin that body is producing and keeps putting out the glucose or inappropriately high glucose production by the liver. And also muscle resistance would be that that glucose that circulates in the blood, muscles are not taking it up and not utilizing it in a normal fashion. Over time, beta cells need to work really hard. I usually give an example of running on treadmill. So beta cells need to run on a treadmill with the insulin resistant for 24/7 to be able to maintain this higher insulin production in order to compensate for the insulin resistance. So at some point, if you imagine running on a treadmill 24/7, obviously you get tired. So do the pancreatic beta cells that produce insulin. So they do get tired, and the insulin production reduces or decreases over time. And there is a mismatch between how much body needs the insulin to overcome that insulin resistance and how much pancreas is able to make of the insulin. So at that point, a person develops early onset or beginning of diabetes, pre-diabetes that can convert to diabetes as condition worsened. So patients may have various types of prediabetes. So that can include impaired fasting glucose. So it could be isolated, just fasting blood sugars being elevated. It could be just impaired glucose tolerance, meaning those higher blood sugar spikes just after the meals, but normal fasting glucose, or most commonly, it would be both. So what is the natural history of this prediabetes and then development of diabetes? So initially, if you look at this lower graph, and the sort of the pathophysiology, and again, it could be years before the diabetes actually develops. So initially, the insulin resistance getting worse, and fasting insulin increases. And then again, as we said, over time, it's not able to maintain this high production. So the level goes down, but insulin resistance stays at the same level. So what happens with that time, with the blood sugars at that time? So during that period of time, for blood sugar, for fasting glucose start rising. And as you can see, that postprandial or post-meal glucose rising as well. So this is when we are seeing the 0.0, that's when individuals develop diabetes. But again, it can precede years and sometimes decades to develop it. So during that time, as we mentioned, beta cell sort of start declining with their production of the insulin. This is the beta cell function comparing to what it should be normally. And we can see again at the point of 0 with continuous decline in the beta cell function. So we don't call it absolute insulin deficiency or absolute insulin deficiency of the insulin production. It's sort of relative deficiency. It's relative to the body's requirements of the insulin. So it's about 40% relative decrease in the beta cell function in individuals with prediabetes, with continuous further decline in the beta cell function as it progresses to diabetes. So what are the major risk factors for prediabetes? Body mass index, which is weight in kilos by height in meters squared. Over 25 is considered the overweight, and so for Asian, it's over 23. Older age, physical inactivity, unhealthy diet, and then genetic predisposition is really, really important. So we talked about the categories of prediabetes. So again, one would be impaired fasting glucose. So normal fasting glucose be less than 100. So for prediabetes, it would be between 100 and 125, and 126 or higher, that's already qualifies for the diagnosis of diabetes. For the oral glucose tolerance test or post-meal glucose, normal would be under 140. For pre-diabetes, it's 140, between 140 and 199. And if it's over 200, that's already qualifies for the diagnosis of diabetes. So again, the blue part is classified as impaired fasting glucose, and the red is impaired glucose tolerance. And again, frequently we see both. So most of the studies that have been done in individuals with the impaired glucose tolerance. So it's more common, and earlier we see impaired glucose tolerance than impaired fasting glucose. So what are the complications of prediabetes? Do we need to worry about it, or do we need to just wait until diabetes develops? And what is important for us to know to be able to understand what is the significance of this condition? So one, and of course, the most important one is the progression to diabetes. So again, the cumulative incidence of diabetes is about 31% for impaired fasting glucose during 12 years, and 41% for impaired glucose tolerance. So usually impaired glucose tolerance, part of the prediabetes is considered sort of higher rate of progression to diabetes. So age of prediabetes when it develops, and the higher A1C. So hemoglobin A1C, if it's 5.7, 5.8, is just borderline to the normal. So if it progresses to 6 to 6.4, again, that's a risk factor. We already know that it's getting towards the diabetes. The risk is higher in individuals who have both impaired glucose tolerance and impaired fasting glucose. So both types of prediabetes. So it's interestingly, or unfortunately, that both micro and macrovascular complications actually start developing at the stage of the prediabetes. And that is why we're concerned when patient gets diagnosed with diabetes or overt type 2 diabetes. We're already screening for complications at the time of the diagnosis, because we know that prediabetes could have persisted for years preceding the diagnosis of diabetes. And because the prediabetes itself is associated with complications. So the recommendations from American Diabetes Association is screen for all the complications at the time of the diagnosis with diabetes. So what are those complications? The complications could be macrovascular, or mostly related to heart disease. So there's a higher cardiovascular disease risk than individuals without prediabetes. Their high rate of hospitalizations, their high rate of mortality from cardiovascular disease comparing to individuals who have normal blood sugars. For microvascular complications, that includes the small vessels, and those are the eyes, the nerves, and the kidney. So proportion of patients with prediabetes who already have nerve involvement or neuropathy is up to 16%, which is pretty high. So sometimes patients present with prediabetes and already fairly significant symptoms of the neuropathy. Retinopathy, which is the eye involvement from diabetes, is up to 8% per diabetes prevention study. And kidney involvement can be up to 10% also in patients with prediabetes. So it's not just a sort of benign conditions that can be ignored, but need to be alerted. The patients need to be alerted early on to prevent development of all those complications. How do we treat it? So the diabetes prevention trial, the patients were randomized, and again, as I mentioned before, that most of the trials included patients with impaired glucose tolerance, not with the isolated impaired fasting glucose. So some patients were randomized to lifestyle modification program, and that included healthy eating and physical activity. That patients had scheduled for 16 individual core sessions during the first 6 months, and then followed twice monthly for in-person. That obviously was back in the 80s, so this was way before COVID, so in-person sessions were more readily available at that time. So it was twice monthly in-person maintenance session and followed with the phone calls in between those sessions. Some patients were randomized to metformin, and there was a placebo group. So as you can see on this graph, this is the X is the years from randomization and the cumulative incidence of diabetes. So you can see that metformin prevented prediabetes by 31%, but lifestyle, again, it was more probably intense in terms of the follow-up, right? Because patients sort of felt that they enrolled in the program, they were more involved and more engaged in the exercise program and healthy eating. So 58% of diabetes over 3.5 years of follow-up, or almost 4 years of follow-up, was prevented with lifestyle modifications. So obviously, this is the most effective way of preventing diabetes from prediabetes, but as we all know, it's not easy to follow. So the same trial, the same patients have been followed for longer. So this is the data from 10 years of follow-up. And you can see that the lines stay sort of in the same kind of order. So the best for the lowest incidence would be the purple line, accumulation of with the lifestyle, then followed by metformin, and higher rate of development of diabetes in the placebo group. So the keys for success were weight loss, reduction in total calories, and achieving 150 minutes of physical activity per week. So those are as long as patients were persistent. But again, the 10-year mark was already when the patients were not going through this intense program. This was just a follow-up and analyzing data. So how do we approach the prediabetes, and how do we try to prevent the development of diabetes? So we usually, when we see patients in clinic, we asked about family history. So because that's a significant risk factor, as we said, genetic risk factor is a very important one. Older age, overweight or having obesity, being physically inactive, having history of gestational diabetes is important. So for women who had history of gestational diabetes, the risk of developing diabetes is really high. It's more close to 50% in the next 3 to 5 years after delivery of the baby. Then we do the risk factor, the base screening of the test. So as we mentioned, that for the screening test, we would do fasting glucose, 2-hour post-meal glucose or post-glucose load, and we check the hemoglobin A1C. So there always come to the question, should we start metformin therapy for prediabetes, or should we wait until diabetes develops? So American Diabetes Association recommended to start actually metformin therapy, because if you're here and you already tried your lifestyle but were not very successful, or still not, condition is getting worse and hemoglobin A1C gradually going up and gets to over 6%, and fasting glucose gets to over 110%, body mass index over 35, or a history of gestational diabetes with the age of less than 60, American Diabetes Association recommends considering metformin therapy for those individuals. And of course, the patient preference is extremely important, because if patient does not like to take pills, or would like to get more strict with the diet and with the exercise, then you can give another chance to try. So for lifestyle intervention, contact the therapy team. So it would be nice to have frequent in-person visit with your doctors, followed by less frequent visit than self-monitoring. So there are studies looking at, I think it was, I remember 5-7 years ago, the study was published in New England Journal, which is one of our most reputable journals, looking at patients who actually check their weight at least once a week are more likely to be able to maintain their weight, comparing to the individuals who just judge sort of, or decide their weight gain or weight loss just by how tight the clothes is. So try to consider getting home scale and monitoring your weight. Keep the records of the food types, the portions, the calories, minutes of your physical activity per week, how many steps taken each day. Try to make dietary modifications. So decrease caloric intake by at least 500 to 700 kilocalories per day. Targeting the higher calorie dense foods, such as saturated fats and simple sugars. Involve in physical activity, which is, as we discussed before, over 30 minutes per day, more than at least 5 days per week. Target the weight loss. Goal for individuals typically to lose over 7% of the body weight if in the overweight or obese category. And very important to promote smoking cessation, improved sleep hygiene, and stress reduction. So again, if all of this lifestyle not able to achieve, that's consider for metformin therapy. So one thing that I didn't mention, who is on long-term metformin therapy, metformin sort of tend to deplete vitamin B12. So we recommend periodic checking for vitamin B12 deficiency. So again, lifestyle modifications always is a preferred initial approach after the prediabetes diagnosis. This is recommendations by American Diabetes Association. It has not been tested and specifically in randomized clinical trials. So what are the conclusions? Is that prediabetes is associated with increased risk of diabetes, cardiovascular events, mortality from cardiovascular events. First-line therapy include lifestyle modification that provides us the largest benefit with weight loss and exercise, and metformin can be considered in the patients with the indications that I mentioned. And frequently, over the age of 60, we offer patients metformin therapy as well. So I'm happy to take questions. I know I can see there are some questions in the chat.
Yeah, you have one that's been in the Q&A for a while. I'll ask that first. I just realized maybe we need a little more clarification, but this person is asking, how do you differentiate between liver and muscle resistance? Are there different treatments?
So it's clinically, it's not possible to differentiate. It's like research diagnosis, the research tests that are done in research settings. But because we have three major organs in the body that can be insulin resistant, that's the fat tissue, muscle, and liver insulin resistant. We don't differentiate between those three, so all three need to be kind of addressed at the same time.
Okay, great. And then somebody else is asking, do children of women with gestational diabetes have a higher chance of getting diabetes?
Yeah, that's a really good question. So there are many studies looking at that, what we call offspring of mothers with gestational diabetes. So yes, so there is increased risk in children to develop diabetes later in life and to be overweight. So the studies had been done looking at kids at in their teens years and looking at the prevalence of obesity, overweight, and yes, there is an increased risk. And unfortunately, we are seeing a lot more diabetes and pre-diabetes in children.
Great. And actually, I have a question as well, and then I'll wait for more questions to come in as well. So when you look at the DBP study 10 years out, do you, like with diabetes type 1, there's like a legacy effect? Do you think that because they were in a program and maybe A1Cs went lower for that year, there was like a protective effect for the future 10 years? Or do you think that for the next 10 years, they kept up all the lifestyle management so rigorously? Because 10 years is a long time to be so intent on your lifestyle management.
Yeah, so I don't think we have like the survey questions for these patients. I haven't seen those studies to see how well they maintained their intense lifestyle, what they've learned during the first 3.5 years being in the study. But it could be, so what Leah had mentioned in type 1 diabetes, we have this what we call legacy effect. So once from the time of the initial diagnosis, if you keep tight control, then even 10, 15, 20 years down the road, your rate of complication is still lower comparing to the individuals who did not take care of their diagnosis from the time of the diagnosis. So it's probably part of that. It could be a combination of patients who learned already the sort of the more intense lifestyle and maintain their lifestyle or in a similar way what they've learned during their intense program.
Okay, great. Thank you for that. I rarely ask questions, but I feel like we have you in your brain. I feel, yeah, definitely the desire to.
Yeah, that's a wonderful question. It's a great question.
What about, the same person is asking for the three, the liver and the muscle, and she wants to know the third organ that has resistance.
I'm sorry, can you repeat the question?
Oh, yeah, the question from before with the insulin resistance, I think you said there are three places in the body, the muscle, the liver, and she wants to know the third, what the third place is.
Oh, the fat tissue.
Okay.
Yeah.
And then also someone wants to know what metformin therapy is.
Yeah, so metformin is, or metformin or glucophage, that is the fairly old medication that we have on the market for 5+ decades. And it's been used in the past as a first-line therapy for diabetes. And recently, I think it's in the past maybe 10 years only or even less, that it's been included in the recommendations as a treatment for pre-diabetes. So metformin, the main action of metformin is telling liver not to produce that extra glucose. And because, as we mentioned, that the liver is one of the main organs for the insulin resistance. And despite bodies producing more insulin, the liver still produces more and more glucose when the body doesn't need it. So the main function or the main mechanism of action of metformin is to provide this kind of signal to the liver saying not to produce any extra glucose. So that is the main function. I can see that in the chat. That is the question is about what are the side effects of metformin. Yeah, so side effects are mainly gastrointestinal side effects, which would be some stomach discomfort, cramps, some diarrhea or loose stools. So those would be the most common ones. So we usually start at a very low dose or lowish dose with 500 milligrams, 1 tablet daily, taken after the largest meal. So that sort of helps preventing those side effects. And do not increase the dose until you kind of got used to the slow dose, and then increase as needed.
Great. You have a lot in the Q&A as well. Someone asked if lifestyle changes are not successful and metformin is taken, could improved lifestyle changes result in ending the metformin medication? And then there's a part 2 and 3. It says, what are the side effects of metformin? Oh, you already answered that. And how long can metformin be used?
Yeah, so maybe I'll start with the last one. So metformin can be used for a long period of time. So there's no time limit when you need to stop metformin. And usually patients use metformin for decades. And it's been successful. It's actually, I don't know if you follow any of the, even in the lay literature, there are articles that metformin being used as anti-aging agent. And there's some data available that metformin can prevent certain types of cancer. So all the good effects are available from metformin. So it's reasonable to, if you're not able to achieve your goal with just lifestyle modifications, it's reasonable to start metformin, to try metformin therapy. Again, it depends on what's the individual BMI, body mass index is. You may be qualified for other medications, such as with more effective weight loss, such as glucagon-like peptide. We have several of those medications that are approved for weight loss, and weight loss will help with the reducing the risk of progression to prediabetes, from prediabetes to diabetes. So it doesn't have to be metformin. And now American Diabetes Association more emphasizes that to evaluate individuals for cardiovascular risk disease factors. So if you already have pre-existing heart disease, let's say some stents placed in your heart, and you're overweight, you might consider other medications like metformin to have more effective weight loss. I don't know if I answered your questions.
Yeah, I think it definitely did. And then you actually have a couple of people asking a very similar question, but is A1C age dependent? And then to tag on to that, if you're older than perhaps 70 years old, is there a different standard that you would look at?
Yeah, so great question. So A1C, yes, it's good that you mentioned. A1C does physiologically increase with age. And that increases with age because hemoglobin A1C is a measurement. Actually, I should have left it, but I pulled it out of my slides just for, it was what A1C is. So it's basically the sugar kind of coating the red blood cells or hemoglobin molecule. So the older we all get, our body sort of slows down on the speed of the production of those red blood cells. So the slower the speed, the more the older cells circulating, or the older molecules of the hemoglobin circulating, the longer it keeps that memory of that glucose. So therefore that glucose, the A1C levels could be slightly higher, and they're approximately physiologic increase in the hemoglobin A1C level. It's about 0.1% every few years. After the age, I think, of 60 or 65. So that is a great point. So it is an increase, physiologic increase of the A1C, but usually it doesn't reach to the point that, a person get diagnosed with prediabetes. if your A1C was normal to begin with. So if you started with A1C of 5.2, you have that plenty of room to get with physiologic increase of the A1C and don't get to prediabetes. But if you were already borderline, if you were 5.6, 5.7, you're super close to get to 5.8 or higher to be diagnosed with prediabetes. So again, it depends where you are, it depends what your age is. Yeah, but in this case, you would consider some treatment because still, despite that it's physiologically increases with age, you're still, at a higher risk for development of diabetes. And is there a specific cutoff for age? No, it's not for hemoglobin A1C.
Great. And then somebody's asking, are there tests to assess beta cell function?
So they are. It's usually we do this in research. The simple test in the clinic would be to do what we call the C-peptide test. That's a simple test that is done just by the blood test, and it's done at the same time when we measure the glucose level. And that's also a great question because we do frequently check these levels because we want to distinguish between more of the insulin resistant and insulin deficiency. Some patients with insulin resistance will have actually fairly high insulin, not insulin, the C-peptide levels. But patients who are insulin deficient, and we may use different treatments, the C-peptide levels will be low.
Okay. And then someone's asking, can you speak more on fat cell resistance to insulin?
So again, fat cells is one of the three main organs that are insulin resistant. So fat cells sort of serve several different functions. So when we eat, we break down our fats into different particles. Some of those particles are triglycerides and also fatty acids. So our fat cells, especially the subcutaneous fat, serves as a storage place for those triglycerides and fatty acids. So that's kind of normal. So insulin promotes those triglycerides to go into those and fatty acids to go into those fat cells and being stored there. That's a normal process. So if the fat cells are insulin resistant, they are not taking up those particles for storage and they circulate in the blood. So when they circulate in the blood, they further increase in the insulin resistance. So you get into that kind of snowball that worsening of the insulin resistance can cause, worsening of the higher level of the circulating free fatty acid, and again, further worsening of the insulin resistance.
Thank you. That was a great way to explain it. And then someone's asking, can you explain why smoking cessation is important for prediabetes?
So smoking is like a stress sort of for the body. That's one. So it's like stress hormones can be increased because a lot of people use that for I'm not keeping yourself awake, but kind of like a replacing with coffee or with the coffee, right? So that's like a catecholamines or like a stress for the body. So that increases the blood sugars, further increases insulin resistance. Smoking affecting the blood vessels, which is the most important thing. So it making blood vessels more stiff and less kind of contractible and less adapting to the blood volume, and also causing inside the vessels and kind of inflammatory reaction that makes the circulating cells stick to those to that inflamed we call it intima of the blood vessel and form the plugs that further can rupture and can go into the brain and cause the stroke or go to the heart and cause the heart attack. So because diabetes itself, it's sort of a chronic kind of low grade, so it's inflammatory state. With smoking, it further increases that effect on the blood vessels and like many folds increases the risk of cardiovascular disease.
And then someone's asking about kind of your patient panel and if you see patients living with prediabetes, Dr. Basina.
Usually we have classes for prediabetes. We refer patient to diabetes care program for series of classes or individual visits. Yeah, usually in endocrine clinic, we don't necessarily see patients with prediabetes.
Okay, and then the last question, I see someone's asking if somebody has maybe fatty liver or something else going on with their liver, if that puts them at an increase of for prediabetes.
If they have liver insulin resistance
or like I think fatty liver or
oh yeah,
they
so fatty liver is a part of the whole syndrome. So we call that metabolic syndrome or syndrome X. That is the so fatty liver is really, really important point to make, that it's actually the highest cause of the need for the liver transplant in the United States. So that's really, really important to catch that early on the sort of the fatty liver disease state before it goes into the liver cirrhosis, which would be irreversible stage of the liver disease. And it's really important to evaluate for that. So we actually have our liver clinic. They're very concerned about the growing kind of epidemic of the fatty liver disease. So they got the whole grant on the fatty liver disease clinic. So it's a specialized sort of sub clinic in part of our liver clinic specialty in the gastroenterology, because we're seeing more and more, and again, indications for that is the main indication and the frequency now of the use of the liver transplants for liver cirrhosis due to the started with the fatty liver disease. Yeah, so that's extremely important point.
Great. And then one last question, also clarifying that one. This person wants to know about liver detoxifying foods and if that will improve the liver insulin resistance.
I'm not sure, Leah, probably that's question to you. I'm
Yeah,
not sure what those detoxifying foods are.
I mean, I would just say a healthy diet rich in fiber, fruits and veggies, lean proteins are really healthy for your liver and pre-diabetes. And then, of course, resistance training, it just decreases all insulin resistance. But I haven't seen a study that shows like a specific food that sort of detoxifies the liver that would really make this big change. But those lifestyle things that the diabetes prevention program really highlights really will increase overall insulin resistance in all three places. And then I think those are all the questions, Dr. Basina. I think you got the most questions out of any talk. This will definitely be posted. Oh, one other person asked, does metformin help with liver insulin resistance? One last question.
Yeah. Great question. So there is a misconception that metformin is the insulin sensitizer. So metformin does not help with the insulin resistance. So metformin, what it does help, again, it reduces, so through the mitochondrial changes, it sort of sends a message to the liver not to produce extra glucose. So when you lower, so basically that's how it lowers glucose in the blood. So when the lower the glucose in the blood, the less of the sort of exertion or the less demand for the pancreas to make more insulin. So that's how it works. So it's not insulin sensitizer.
Great. Yeah, so I think those are all the questions. Thank you so much, Dr. Basina. We hope to see you all next month as well. We have a diabetes medication cost savings talk. So it's the second Thursday of every month, 5 to 6. And yeah, thank you so much for sharing all your knowledge and answering such an array of questions, Dr. Basina. This will be posted
all the
on
excellent questions.
Yeah, this was a very really focused group and had lots of great questions. So hope everyone has a great night. Bye. Thank you.
Thank you.